Okay, let's unpack this. Welcome to the deep dive. Today we're doing something a little different, but definitely in the spirit of getting smart fast. You've shared a stack of your revision notes with us, all focused on one specific topic, meningioma.
That's right. And our mission, sort of working through this material you've given us, is to be your expert guides here. We're going to cut through these notes, pull out the really high-yield stuff, and basically give you a structured walkthrough.
Yeah, think of it like a shortcut to really getting what's in your notes, whether you're revising, trying to get up to speed quickly, or maybe just curious.
Exactly. This deep dive is specifically for you. We're taking your notes, covering everything from, what meningioma is, why it happens, how it presents, management outlook, all of it.
We'll pull out the key facts, help connect the dots, and hopefully make this, well, complex topic click.
Let's dive in.
All right, so starting right at the beginning, from the material you shared, what is a meningioma? Fundamentally, where does it come from?
Okay, so the definition provided is pretty clear. It's a primary brain tumor. But the key detail really is where it starts. It comes from the meninges, those protective layers around the brain and spinal cord.
Right, the coverings.
Exactly. And specifically from cells called meningothelial cells. These are found in the arachnoid mater, which is, one of those three meningeal layers.
So it's not actually brain tissue itself, but the covering? And the material mentions they're typically slow growing. That seems important.
Absolutely. That slow growth is definitely a key characteristic mentioned in your notes. Now, how we understand and classify them is crucial, and your notes highlight the WHO grading system. This isn't just about size, it's about, how aggressive they might be.
Okay, walk us through those grades then. What does the WHO classification tell us about how they behave?
Right, there are three main grades based on the material you shared. Grade O, these are the most common, usually considered benign. Their growth is typically slow, yeah, but even slow growth can cause issues just by taking up space and pressing on important brain structures.
Ah, the space-occupying effect.
Exactly. You could maybe think of grade 1 as generally being the good one in this system, lower risk, slower growth. That might be a helpful memory tip.
Okay, grade 1, the good one. What about grade 2?
Grade 2, these are termed atypical. They show some features that mean they grow faster than grade 1st, and importantly, they have a higher risk of coming back, of recurring, especially if the surgeons can't get the whole tumor out.
Okay, faster growing, higher recurrence, and grade 3.
Grade 3 are the malignant ones. Thankfully, these are rare, but they are aggressive. They show local invasion growing into nearby tissue, they have a high chance of recurring, and in rare cases, they can even spread elsewhere in the body. Metastasis.
That grading really paints a picture of the potential behavior.
Yeah.
Your notes also mention a couple of other specific things. Meningioma en plaque.
Yes, that's mentioned. It's described as a rare, diffuse subtype. So instead of a sort of round lump, it spreads out more like a sheet along the meninges.
Interesting.
And there's a specific note about the chordoid type being linked to Castleman's disease. Castleman's is an unusual lymph node disorder, so that's quite a specific association noted in your materials.
And they aren't just in the head, right? The notes say spinal canal, too.
Correct. The material is clear. They can occur intracranially or down in the spinal canal.
Okay, so we know what they are and how they're graded. Let's switch gears. Your notes move on to etiology and risk factors. Why do these actually develop? What do the notes say?
Well, the material states up front that the exact cause isn't fully understood for every single case, but it does list several factors they've identified.
Like what?
Genetic factors definitely play a role. Mutations in genes like NF2 and AKT1 are specifically called out in your notes. NF2, for instance, is a known tumor suppressor gene, so a mutation there makes sense as a risk factor.
Okay, genetic links. Anything else?
Hormonal factors are also mentioned, specifically estrogen exposure. This might help explain the gender difference we'll probably touch on later.
And there was a list of explicit risk factors you pulled out.
Yeah. Exactly. The notes list family history, certain genetic syndromes, neurofibromatosis type 2 is specifically mentioned. Again, linking back to that NF2 gene radiation exposure, particularly the head and neck.
Right.
Gender, with women being more commonly affected, advanced age, and also a history of head injury.
Interesting about the head injury link.
It is. And the notes also add a mention of a possible link to breast cancer, though they are careful to say the causality isn't really clear from the source material provided.
So quite a mixed genetics, environment, demographics. You mentioned earlier that they can occur in lots of different places. Your notes seem to really emphasize this point.
They really do. The list provided is quite extensive.
Hmm.
The skull vault, the top dome, bit the skull base, which is complex, places like the sphenoid wing or pitris ridge. Also where the meninges fold over, like the falx cerebri between the two halves of the brain, the tentorium cerebelli over the cerebellum, even the sheath around the optic nerve, the choroid plexus where CSS is made.
Wow, almost anywhere.
Pretty much.
Yeah.
And rarely, even outside the central nervous system entirely. A good memory tip might be just to think broadly. They can pop up almost anywhere you find meninges.
That explains why symptoms can vary so much. Before we get to symptoms, though, your notes mention some specific markers, MIB1 and Ki67. What are those about?
Ah, yes, those are proliferation markers. Basically, they give an indication of how fast the tumor cells are dividing, so a higher level might suggest faster growth and a higher risk of recurrence.
Okay, markers for growth speed.
The notes also mention progesterone receptors correlating with prognosis.
Well,
Interestingly, having a lot of these receptors might suggest a slightly better outlook. And another point, really relevant for detection, 70% express somatostatin receptors. This is actually used in certain scans to help find them.
Linking the marker to the investigation. That's useful. Okay, let's try and simplify the core pathophysiology mentioned. What's the basic mechanism here? What's going wrong once these cells start growing?
Right. So as we said, they start from those arachnoid cap cells. The core problem, as highlighted in your notes, isn't usually that they're aggressively destroying brain tissue like some other tumors might. Instead, it's primarily mechanical.
Mechanical.
Yeah, because they're growing inside the skull or spinal canal, which is a fixed space, right? So as they get bigger, they just push on or compress whatever's nearby brain tissue, cranial nerves, blood vessels, the spinal cord itself. This compression and displacement, that's what causes most of the symptoms.
So it's that space-occupying lesion effect we talked about.
Got it. Now, thinking diagnostically,
Yeah.
if someone presents with symptoms that could be a meningioma, what else needs to be considered? What are the main differentials listed in your notes?
Yeah, the notes give a solid list of differential diagnoses. The big one, obviously, is other types of brain tumors. You need to distinguish a meningioma from things like gliomas, which come from the brain's support cells,
Right.
schwannomas, which arise from nerve sheaths, and metastatic tumors, cancers that have spread from somewhere else in the body. So rule out other tumors first. What else is on the list?
Metastases are actually listed separately too, with specific examples like lymphoma and adenocarcinoma. So it emphasizes that cancer from other organs can present as a mass in the brain area.
Okay.
Beyond tumors, inflammatory conditions like sarcoidosis are mentioned. Sarcoidosis can cause these inflammatory masses, granulomas, that can look like tumors on scans.
I see.
And infections too. Something like tuberculosis, for example, can cause lesions in the brain or meninges that might mimic a tumor. The notes are very clear. Imaging and then getting a tissue sample, histopathology, are absolutely essential to know for sure what you're dealing with. Can't really skip that step for a definitive diagnosis. It's crucial.
That definitely highlights the need for the investigations, which we'll cover shortly. But first, let's zoom out a bit for the epidemiology. How common are these? Who usually gets them, according to the UK-specific data in your notes?
The UK data is quite striking, actually. Meningiomas are the most common primary brain tumor. They make up a big chunk, 30% of them in the UK.
30.
Yeah. And if you look at all adult central nervous system tumors, they account for a full 1/3. So that 1/3 statistic is a really good one to remember. They're a major player in adult CNS tumors.
1/3, okay, easy enough. And the typical patient profile? Age, gender.
They're most commonly diagnosed in people aged between 40 and 70. And there's that gender difference we mentioned earlier. They are about twice as common in females compared to males, a 2.1 female-to-male ratio.
2 women for every 1 man, roughly.
Generally speaking, yes. And that probably links back to the hormonal factors, the estrogen exposure mentioned in the etiology section of your notes.
Makes sense.
Now, here are a couple of really interesting stats from the material. Your notes state that, surprisingly, maybe 2–3% of the general population actually has asymptomatic meningiomas. They're just there, often small, not causing any trouble, so they haven't been found.
Wow, 2 to 3% just walking around with them unknowingly. That seems quite high.
It does, doesn't it? And another interesting fact pulled from the notes, about 8% of people who are diagnosed with a meningioma actually have multiple tumors. So finding one means you should probably look carefully for others.
Good point. Okay, let's move on to how these actually present the clinical presentation. Your notes say the symptoms are incredibly varied.
They absolutely are. And it makes total sense when you think about all those different places they can grow, right?
Yeah.
And the fact they cause symptoms by compression. The symptoms depend hugely on the tumor size and, critically, its exact location.
So what are some of the common ways they show up based on the notes?
Well, Common symptoms listed include headaches, seizures, and these can be focal, just affecting one part, or generalized neurological deficits like weakness, numbness, maybe vision problems,
Uh-huh.
and cognitive changes. That can include personality alterations or problems with thinking and memory. Maybe a mnemonic could help here, like HSNC. Headaches, seizures, neurodeficits, cognitive changes. Just an idea.
HSNC, not bad. That covers the main categories. And linking back to that asymptomatic stat, many are found just by chance.
Yes, exactly. As a note state, it's pretty common for them to be found incidentally, imaging done for some other reason because they often grow so slowly. Someone might be symptom-free until the tumor gets quite large. The notes specifically mention this idea of delayed symptoms.
So you could have a fairly big tumor but feel fine until it finally hits something critical. What about some more specific or maybe less common presentations mentioned?
The notes list things like raised intracranial pressure. Basically, the tumor increases pressure inside the skull.
Yeah.
That can lead to worse headaches, nausea, maybe vomiting, and potentially hydrocephalus, a buildup of cerebrospinal fluid.
Right.
There could be neuropsychological effects too, like altered personality or disinhibition mentioned. Specific neurological features really depend on which cranial nerve or brain area is getting squashed.
Ah.
Vascular events like TIAs, mini strokes, or even bleeding are possible, though less common. And visual field defects are pretty common if the tumor is anywhere near the optic pathways.
And your notes gave a couple of really distinct location-specific examples. Can you share those? They really highlighted the variety.
Yes, these are great examples from the material. If a meningioma happens to be located in the sella turcica area that's at the base of the brain, near the pituitary gland, it can compress the pituitary and cause panhypopituitarism. Basically, the pituitary stops making enough hormones.
Wow. Okay.
Or another example, if a meningioma is in the spinal canal and presses on one side of the spinal cord, it can cause Brown-Séquard syndrome. That's a very specific pattern. Weakness on the same side as the tumor below that level, but loss of pain and temperature sensation on the opposite side.
Fascinatingly specific.
It really is. Thinking about an example coffin might help cement these, like what rare endocrine issue might a sella turcica meningioma cause? Panhypopituitarism. Or how does Brown-Séquard's from a spinal meningioma affect each side? Weakness, same side. Sensory loss, opposite side. That forces recall.
Those examples perfectly show how location is everything for symptoms. So if someone presents with suspicious symptoms, maybe one of those patterns, what are the key investigations? How do we confirm it, according to your notes?
Imaging. Imaging is absolutely the cornerstone here. The notes really emphasize this. The preferred method is MRI, magnetic resonance imaging.
Right, MRI first.
Your notes specify that MRI is great for showing that dural origin, proving it comes from the meninges, and defining these extra-axial lesions clearly. Extra-axial meaning outside the brain tissue itself. So, quick memory tip, MRI is the gold standard imaging here.
And if MRI isn't an option for some reason?
Then CT scans are listed as the alternative imaging method. Useful if, say, a patient has a pacemaker or something else that prevents an MRI.
Okay. The notes also mention something sometimes done before surgery, angiography.
Yes, endovascular angiography. This involves injecting dye into blood vessels to see them clearly on X-ray. It's often done preoperatively before surgery to map out the tumor's blood supply and see how close it is to major blood vessels. Helps the surgeons plan and potentially reduce bleeding risk during the operation.
Makes sense. And the definitive diagnosis. You mentioned histopathology earlier, getting a tissue sample.
That's exactly right. The absolute confirmation comes from a biopsy. Sometimes this can be done stereotactically, that's using imaging guidance through a small burr hole in the skull, but often it's obtained as an open biopsy during the surgery to actually remove the tumor.
Oh.
And the notes reiterate this point.
Right.
While imaging is crucial after a neurological exam to suspect a meningioma, it's the biopsy during surgery that gives the definitive tumor typing and grading. It's the grading first two words here, benign, atypical, malignant. And that information is what truly guides the next steps in management.
So, imaging points the way, tissue sample makes the final call and dictates treatment. Let's talk management then. Once it's diagnosed, what are the main approaches outlined in the notes?
Well, the approach is highly individualized. It depends on the tumor size, location, grade, the patient's age, and overall health. Lots of factors. But the notes list the main strategies. First up is observation.
Just watching it.
Yeah, for small asymptomatic tumors, especially in older patients perhaps, just monitoring with regular scans, often an annual MRI is mentioned, can be a perfectly valid approach. Not every meningioma needs immediate intervention.
So watch and wait is an option. But if it's causing problems or growing?
Then surgical resection is the primary treatment aim listed. The goal is complete removal, if possible. But the notes acknowledge this could be tricky, sometimes impossible, if the tumor has invaded nearby critical structures like major veins or nerves.
Okay. What if surgery isn't possible, or if they can't get it all out?
Then radiation therapy becomes a key tool, according to the notes. It's used when surgery couldn't achieve complete removal, if the tumor comes back later, or for those higher grade tumors, grade 2 and 3, to try and control their growth.
Any specific type of radiation mentioned?
The notes mention stereotactic radiosurgery specifically. This is a very precise technique, delivering a high dose of radiation right to the tumor while minimizing damage to the surrounding healthy brain tissue.
Precise targeting. And
And
that pre-surgical angiography thing, embolization, can that sometimes be a treatment itself?
yes, the notes mention endovascular embolization. That's where they block the blood vessels feeding the tumor. Mostly it's done before surgery to make the operation safer by reducing bleeding. But the material also suggests it can sometimes be used as the main therapy in certain situations, perhaps if surgery is too risky.
And what about chemotherapy? Is that used?
Chemotherapy and other sort of molecular agents are considered, according to the notes, but usually only if surgery and radiation haven't worked or aren't options, particularly for more aggressive or recurrent tumors. However, the notes do state that the results with current chemo drugs are often, well, disappointing. Yeah, but it's mentioned that research into new targeted therapies is ongoing, looking for better options.
So monitoring, surgery, radiation are the mainstays, with other things for specific cases. Did the notes mention anything about managing the symptoms themselves, like with medication?
Yes, dexamethasone, that's a steroid. It's often prescribed, the notes say, to help reduce swelling, the edema, around the tumor. And that can help relieve symptoms like headaches or neurological problems caused by that swelling.
Right, steroids for the swelling. Okay, that gives a clear picture of the treatment options. Let's wrap up by looking at the long-term view. Prognosis and potential complications. What determines how well someone does after diagnosis and treatment based on these notes?
Prognosis really depends on several key factors listed in your notes. The tumor's grade, that WHO grade we talked about, is probably the most important. Then its size and location matter, and critically, how much of the tumor could be surgically removed. The extent of resection is key.
Okay.
For the typical grade I meningiomas, the slow-growing, usually benign ones, the prognosis is generally favorable. If the surgeon manages to remove the entire tumor, the notes say the prognosis is often excellent.
So complete removal of a grade 1 is the best case scenario. What about the higher grades or incomplete removal?
As you'd expect, more aggressive tumors, or ones that keep coming back, definitely impact the long-term outcome negatively. The atypical grade 2 and anaplastic grade 3 meningiomas inherently have a poorer prognosis. Even though distant spread, metastasis is rare, even with grade 3, their risk of coming back locally is much higher.
Right.
Regular follow-up, keeping an eye on things with scans, is essential for everyone, but especially crucial for those higher grades or if the initial surgery wasn't complete.
Your notes give some 5-year survival rates, don't they? That helps put numbers on that difference.
They do. It's stated that for completely removed, typical grade 1 meningiomas, the 5-year survival rate is around 80%. But for completely removed malignant or atypical grade 3 ones, it's significantly lower, less than 60%.
That's a stark difference.
It really highlights why that grading is so critical. So an example question to ask yourself might be, what's the rough 5-year survival difference between a typical and a higher grade meningioma after complete surgery? Remembering that 80% meninges to 60% difference is important.
Definitely. Finally, what are the potential complications someone might face, either from the tumor itself or maybe the treatment?
The notes list several potential issues. Ongoing neurological deficits are common, and they vary hugely depending on where the tumor was and what got affected. Seizures can persist or develop after treatment.
Oh.
Cognitive impairment, memory problems, things like that, and other functional limitations can also occur, again, depending on size and location. There's always the risk of the tumor recurring or progressing, even years later.
And treatment side effects.
Yes,
Yeah.
side effects from the treatments themselves are also listed as complications, for instance, potential long-term effects from radiation therapy. The notes really reinforce that comprehensive care means ongoing monitoring and managing these potential complications over time.
That really takes us through the entire journey, doesn't it? From the cell it starts in all the way to the long-term outlook and potential bumps in the road. We've basically taken that stack of notes you shared and broken it down section by section.
And hopefully, by structuring it like this, pulling out those key details, the WHO grades, the risk factors like NF2 and radiation, the huge variety in location and symptoms, the MRI focus, the management steps, hopefully. It makes all that information feel a bit more manageable and easier to recall for revision.
Absolutely. And maybe just a final thought to leave you with, building on that idea of location and symptoms. It's really quite remarkable, isn't it, how a tumor starting from the exact same type of cell, those meningothelial cells, can cause such drastically different problems. One person might just get headaches or a seizure. Another could end up with, say, complete pituitary failure because of where it grew near the cella turcica, or that incredibly specific Brown-Séquard syndrome pattern from a spinal one.
Yeah, it's a powerful illustration.
It really underscores the intricate, precise mapping of our nervous system and just how sensitive different areas are to disruption purely based on where that growth happens.
A perfect example of how location is everything in neuroanatomy and neuropathology.
It certainly is. Well, thank you so much for sharing your notes and letting us do this deep dive with you today. If you are looking for more resources to help with revision, definitely check out PASMSRA.com.
And you can also find lots of helpful materials over at freemsra.com.